Guess what time it is? Oh, you know it, straight up 4 o'clock in the mountain time. And I'm Dr. Randy Fink. Welcome to Fertility with Fink and Friends, live from CNY Fertility in Colorado. Beautiful Colorado Springs. Happy to see everybody with, 6 o'clock on the East Coast, 5 p.m. in the Central Time, and 3 o'clock to our friends in the mountains. Nice to see SF. Nikki is the first person here, so you get a special hello from me today. Hi, XOXO, and Caitlin Dubois. Oh, hey, it's nice to see you. Hi. And we've got a couple of different things here. We've got, hi, Jesse. Looks like Jesse Emerald. And the first one over here on this side, I got to say first, One Princess D. Hello, and a special shout out and a welcome to you. Over on the Facebook side, Emily Mortensen from Oregon. Glad to see you. And my friend Haley. Great to see you. And Haley, your card is still sitting on my desk and making me very happy every single day. I hope you are feeling well. Gosh, we've got Brooke from Texas. We've got Alexandra. Nice to see you. And Maddie, CC Journey. We've got Sarah. All these folks here. So let's see. We've got a couple of different Instagram feeds. We've got the CNY feed and my personal feed here, and we've got YouTube and Facebook right here. So gosh, it sure is nice to see everybody, and I hope your week has been great and that your weekend was also just as wonderful, and that your journey on this fertility hi Kirsten, your journey on this fertility roller coaster has been an okay one for you this week. You know, it's always such a challenge, and what I'm fond of telling folks is that, you know, it's quite a roller coaster ride. And if you've heard me say this before, please forgive me for being repetitive. But you know, it's kind of a crappy roller coaster. Hopefully, we know where this roller coaster ends. That you get off at the station with a baby in your arms. But until then, this is the one that flips you upside down. It gives you a concussion. It makes you nauseated. It's the crappiest roller coaster in the park. And I'm really sorry that any of you have to ride it, but I sure am glad that we get to ride it with you. So here in Colorado, we love seeing you folks and love seeing you folks on the lives, but honestly, the same holds true in our New York locations. I understand that Sarasota, Dr. Kiltz told me just yesterday, Sarasota is planned to be up and running on July the 1st. I spoke with Dr. Kondrup late last week, and he was optimistic as well. So let's look forward to July 1st being joined by our brethren in Sarasota. And for all you folks down in the Southeast, a little bit easier for you to have the full service operation of CNY Fertility. So many people to say hello to. Gosh, everybody is joining in. So forgive me for not being able to. Hi, Nikki. Drea, Abby, so many people. I just can't say hi to everybody. So I hope you'll forgive me if I just say hi. Let's see, some exciting things happened this week in the world of CNY. If you're not familiar, what's Elaine saying? Hi from Canada. I don't know why I'm here. I already had my CNY baby. It's because once you're a part of the CNY family, you're just always a part of the CNY family. And congratulations to you for your baby. And we're so happy to have been a part of that. So the exciting news that happened in the CNY world this week is that we announced that there are packages now available that include the infertility treatments, the IVF, and the medications. And that's kind of really big news, because certainly if you've been through the process, you know that the medications are really the most expensive part. So one of the things that I enjoy most about being at CNY is that we are able to provide a service at a cost that really makes this in reach for just about everybody. CNY will finance, CNY will make the dream of having a baby within reach to, like I said, just about everybody. With the packaged medication prices, now we are really able to do that at even at a more affordable rate than ever. Even the medication, after a little bit of money down, the medication can now be financed as well, and each one saves on the order of $1,000 or more on medication. So really just very fantastic news. I will tell you that the different protocols for the medications are not perfect for every person. So sometimes there will be other medications that we might recommend that may not be in those packages. But in general, it's a great place to start, and hopefully that's only going to be good news for everybody. Hey, Roberson 87, Amber here. Hey, Amber, 5 embryos were frozen in Syracuse. That's fantastic. The retrieval was on Tuesday, and I hope that you are feeling well there, Amber. It's for most people after the retrieval, I always tend to say that bloating gets worse before it gets better. Sometimes people will have a little blood in the urine. You'll have a little bit of shoulder pain. You'll have a little discomfort. And that day, certainly you're going to want to go home and take a nap and sleep off the rest of the anesthesia. But hopefully, for most people by that evening, make plans to go out to dinner, see the sights, and then the next day, maybe a little sore, maybe a little slow moving, certainly a little bit bloated still, but the recovery should be pretty quick after an egg retrieval. I got a couple of questions. Actually, the first question I got via email was, what's up with the mullet? Yes, I am sporting a mullet. You may call me either Randy Ray Cyrus or Randy Ray Fink. I think that's probably good. But it's business in the front, it's party in the back. Business in the front, party in the back. And that's what we're doing here. I'm trying to relive my 80s existence because I'm lamenting the rapid disappearance of my hairline. So please don't make fun of me. I'm just a simple country fellow. All right, so let's see here. We've got some questions on the Facebook side. My friend Sally comes from Trinidad, if I'm not mistaken. Hi, Sally. Sally, you already prepaid for the IVF with a promotion of $37.95 and didn't start IVF yet. Can I get the medication at the package rate? That's a very good question. And Sally, I don't know the answer to that one. That one we're going to have to send off to the finance department, and I will certainly ask that question as well. My guess is, since you got the promotion on the IVF price, well, you know what? I'm not sure, but a simple email to the finance department will seek to clarify that. And Brittany's wondering that same thing too. It is a good question, and I'm hesitant to give an answer because I would be entirely making it up, and not like I don't do that all the time. But I want to be able to give you the right answer. So please email the finance department, and that is a good way to solve that question. Okay, BJ Pumping over here on the CNY Facebook side says AMH of 0.016 and 44 years old. Can I use my own eggs? And that's a very good question, my friend. Can you use your own eggs? The answer is yes. Will you be successful using your own eggs? And that's another story, perhaps entirely. The AMH, the anti-Mullerian hormone, tells us about your ovarian reserve. And with a number of 0.016, that tells me that your ovarian reserve is low. It means that we are going to be challenged as it pertains to retrieving your eggs, to stimulating the ovaries, to getting eggs from you. But in addition to the number of eggs, the quality of the eggs will start to diminish as we age. So the truth there is, my friend, that as we start to approach 45 years old, the success rates with IVF go way down. There are many clinics who would tell you, no, no, you can't use your own eggs. You have to use donor eggs. And while I would say that yes, donor eggs are going to give you a higher probability of being able to achieve a pregnancy, you can certainly try with your own eggs. In fact, what many folks do is that they will do a stimulation with their own eggs and a donor egg backup, which means that in addition to once we've retrieved your eggs, we'll fertilize both your eggs and the donor egg or the package of donor eggs that you've purchased, so that either way, you're going to end up with a high probability of an embryo that can get you pregnant. So the lower AMH means that we're going to be challenged with the number of eggs that are left. And based on age alone, we start thinking that the DNA becomes less stable. Is there something you can do about egg quality? And the answer to that is yes. I believe that there is. And that's what we call priming. And many of you may be familiar with priming. Priming is where we do something before you do your IVF in order to try to increase the yield or improve the yield that we get from your IVF cycle. Some of those priming things, first of all, has absolutely to do with the supplements that you take. If you've been on my lives before, you know that I've mentioned feel free to message me through my Instagram, and that's Randy Fink MD, and I'm happy to send you the list of the supplements that we have taken from the book. It Starts with the Egg. It's kind of the quintessential guide to using our own biochemistry to improve egg quality, sperm quality, or even endometrial receptivity as it pertains to those who are doing transfers. We've read the book for you. We pulled out the list. We found the right dosages, found the right formats of these vitamins, found some good brands at good prices, and we put them on a list so that if you want them, they should be easy for you to come upon. The book is written by a woman who herself had low ovarian reserve, but she's a biochemist, and she wanted to know, well, what can I do here? Can I do something that's going to make a difference in my egg quality? So she exhaustively researched all the supplements, what the ones that, what things do and what they don't, and put them in a book that's pretty easy to read. If you haven't read it, I certainly recommend it. But as I said, we read it for you and have that list available. So we know that we're born with all the eggs we will have. We're born with them, and over time, those eggs start to die off. In fact, after the age of 35, we're losing about 10,000 eggs a month until eventually all the eggs are gone. And when all the eggs are gone, that's what we call menopause. It was classic wisdom that as we mature or as we age, that the DNA becomes progressively more damaged. And that's what results in the difficulty in us getting pregnant the older we are. That's why you will see the spontaneous pregnancy rate in women over 45 is very, very low. Absolutely, it can happen, but the rate is low because those eggs are more damaged. So the DNA, the genetic material, is not normal. So it makes an embryo that's not normal, or an egg that doesn't want to be fertilized because it's not normal. And in IVF terms, when we have an egg or we make an embryo that's not normal, those eggs typically will simply not implant. That will never get a positive pregnancy test. Sometimes it does happen. Certainly people do have miscarriages in IVF, but more commonly, we just don't get a positive pregnancy test. Well, the research, the emerging research is showing us that, in fact, it's not age alone that's damaging that DNA. In fact, age may be sort of an initial insult to the DNA, but it's not until about 3 months before that group of eggs is developed and ready to be ovulated that we will see the real damage take place. So there is likely a 3-month or about a 90-day window that we have to be able to improve egg quality before we recruit that cohort of eggs. And that's where the supplements come in. So my friend BJ Pumping, we are going to be limited in the number of eggs, but the quality of eggs we can change. And I strongly encourage you to talk to us about that. There are other things that we can do with priming, sometimes estrogen and progesterone, sometimes omnitrope, which is human growth hormone. Low-dose naltrexone is used in priming. So many things that we can do to try to improve that egg quality. So best of luck to you, my friend. Mrs. Peach, hoping to head our way someday soon, and we hope so too. Hi, Fit and Healthy 26. Nice to see you. KC India, nice to have you there too. Let's see what we've got over here on this Facebook side, and then we'll take a look at our friends on Facebook. JLaugh18, currently 15 weeks with a Brandis transfer. That is wonderful. The entire team is amazing. So thank you, my friend, because it is those kinds of kudos that absolutely keeps us going. In fact, Brandis has created a board with pictures. Everyone who sends a picture or a nice note in of their new babies, we are putting them up. I hope to be able to line the hallways with them, quite honestly, because this is really such a gift to be able to take part in the magic of getting you a family. And thank you, JLaugh, for those kind words. Well, let's see what we have on the Facebook side here. Amber Skelton, nice to see you. Sorry to hear that the transfer didn't work there, and so 2 failed ones so far. Let's not think of them as failed transfers. Let's think of them as unsuccessful transfers. They didn't work, but that doesn't mean that you are a failure. This is a journey that's ongoing, and it's a journey that we are all here with you. As I'm fond of saying when I sign off, infertility is not the title of your book. It is merely a chapter. And what we're trying to do here is to help you to write a new one. So not that it was a failure, just that it was unsuccessful, which means that, another nice quote I heard is that when we walk amongst the shadows, every shadow is created by a light. So my friend Amber Skelton, I hope that the light will soon be shining on you, my friend. Shay Overfield says, do I recommend any over-the-counter meds to help with ovulation or anything to increase sperm for men? So the answer to that is yes. So for people who don't ovulate, and actually this is a really good thing to bring up. I was thinking about wanting to talk about it today, and so thank you for the little poke there to remind me about it. Lots of people are on metformin. Metformin is a medication that is used to treat diabetes. It is a medicine that brings down blood sugar in people who are diabetic. However, metformin is used in patients with polycystic ovarian syndrome because it helps to resume normal ovulation. And one of the things that happens in folks, one of the definitions of polycystic ovarian syndrome is chronic anovulation. Ovulation is releasing the egg, anovulation is when you don't release the egg. So chronic anovulation, not ovulating, this is one of the things that we use metformin for. The other thing in the IVF world that we use metformin for is because it improves egg quality. It makes a big difference in the quality of the eggs. And so in folks who have demonstrated an issue with egg quality, or certainly in folks with polycystic ovarian syndrome, we will often start you on metformin. What's the downside of metformin? And why is everybody not on metformin? Well, I'll tell you. The problem is that what it does and the way it works is that it's driving at the cellular level, it's driving sugar into the cells. And when it drives sugar into the cells, it can damage those cells. The most fragile cells in our body are the cells that line our gut, our GI tract. So as sugar is being driven into those cells start to slough off because they become injured. If there's that much sugar around, they may be injured anyway, but they become injured, they slough off. And so therefore, the most common side effect from metformin is the GI business. It's bloating, it's gassiness, it's diarrhea. It's not a lot of fun. So there are some things that we can do to make metformin better tolerated. So I tend to prescribe the extended release version, and that's the one that I would recommend for all of you. The extended release version is one that you take really just at night when you go to bed. As opposed to something that's taken 2 or 3 or sometimes even 4 times a day. With the extended release, it's only 1 time a day. So that alone makes it, significantly easier to be able to deal with. Secondly, I start with 1 pill. And depending on the dose, it's typically either 1,000 or 1,500. So I'll start with a 500 milligram extended release or a 750 milligram. And I take that 1 pill at bedtime for 10 days and then increase to the second pill. Doing that gives your body a chance to get used to the medication and minimizes some of the GI side effects. So just a couple of helpful little tidbits there. Sometimes when people increase to the 2 pill dose, it becomes a little too much for them. And then all you have to do is just split it up. Instead of taking both at night when you go to bed, take 1 at night and 1 in the morning. There is very, very, very low risk for it dropping your blood sugar because it doesn't so much work that way. So you don't have to worry about it from that regard. But I will tell you, there is also a supplement that you can use that does the same thing. And so, Shay, going back to your question there, is there anything over the counter to help with ovulation? That's what myo-inositol is for. Myo-inositol, or just inositol, is a supplement that you can get, and we have it on one of our recommended supplement lists for those with PCOS. Myo-inositol is available really in any place that sells vitamins or even on Amazon. And it does essentially the same thing as the metformin does. Now, do I recommend that you're on the supplement instead of the medication? It depends. If you have health insurance, then the medication, the metformin, probably cost you $10 or so copay when you get that from Walgreens or from the retail pharmacy, as opposed to getting a supplement. It's probably going to cost you $20 or $25 because supplements that's what they do. They cost a little bit more. And oftentimes with supplements, while we are used to medications being something that we can minimize the dose with, like maybe ideally just once a day, oftentimes with supplements, it may be multiple capsules that you have to take and potentially even multiple times a day. So if the medication is appropriate for you, that's when I recommend it's a little easier to take and a little bit less expensive. But to answer your question, myo-inositol. Crystal Del Hierro. Hi, Crystal, on the Facebook side asked, do we do tubal reversals where we can repair the fibria? Well, there is a type of surgery that we can do when the end of the fallopian tube is sealed closed and the fibria are damaged. And that type of surgery is called a neosalpingostomy. Neo means new, the salpinges are the tubes, and an ostomy is an opening, a neosalpingostomy. Let me just ask my friend to join me here. If you haven't met my friend uterus. This is her. So the fimbria are the portion at the end of the fallopian tubes here, and sometimes this can get sealed over, and the tube can become blocked. So there is a surgical procedure that really any gynecologist should be able to do, and we do as well, where we can open up that portion of the tube and try to create a new opening so that an egg can go inside. One of the risks from doing any kind of tubal surgery is that the damage to the fallopian tube may not be reversible, or we may be able to open up that portion of the tube, but it may scar itself back down again. And that increases our risk for an ectopic pregnancy or a tubal pregnancy, and certainly that's something that we want to avoid. Let's see. We're going to head back to the Instagram side right here. My friend Grace Tongue. My last two transfers ended in miscarriage, and that's very sad to hear because, as I always say, a miscarriage after IVF is absolutely insult to injury. I mean, it's just a horrible thing. So, Grace, our thoughts are with you. One happened at 8 weeks, and one was a biochemical pregnancy. Should I do anything different before we transfer our last embryo? Well, so my conversation with folks when I have a consult about a transfer, about transfers that haven't worked or recurrent pregnancy loss. Different things are happening there. Usually, we want to think about, well, so when was the last time you had the uterine cavity evaluated? I always feel that we want to evaluate your uterine cavity once a year. So I spoke with a lovely patient today who had two euploid or PGT tested normal embryos whose uterine cavity hadn't been evaluated since 2017. And even at that point, all she had done was that she had an HSG. The HSG is the dye test, and it lets us look at the fallopian tubes. It shows us the outline of the uterus, but it's not so great for finding small things in the uterine cavity that can be abnormal. So usually we recommend either a saline sonogram or a hysteroscopy, which is a camera that goes on the inside. And we recommend that you do that once every 2 years. So Grace, I'd want to know first thing, when was the cavity evaluated? And is that up to date? I would want to know anything I could about the lining. We want to know about endometriosis. I'd want to know about the embryos themselves. Were they tested embryos or untested embryos? Because the most common reason for that type of pregnancy loss is due to a chromosomal issue. Certainly, that's what happens in a biochemical pregnancy. We start to see a pregnancy test turn positive, and that ball starts rolling until it realizes, oh, wait a minute, something's not right with this embryo, and then the process starts to reverse itself. Now, even in a tested embryo, or one in which we believe that the chromosomes are normal because they've done the PGTA testing, we can still have pregnancy losses. And why is that? Well, the PGT testing tells us that the portion of the embryo that they biopsied, which is the portion that's called the trophectoderm, and that's the part that becomes the placenta, that the placental portion was normal. But we don't know about the other part. We don't know about the baby. They're not taking a piece of the baby. They're only taking a piece really of the outside. So you can have a normal placenta with an abnormal embryo, or vice versa. You can have an abnormal placenta with a normal embryo. So that's why even a PGT tested abnormal embryo may give you up to a 15% chance of having a normal baby. It's not a perfect system. So there are a lot of questions that go into that one there. Let's see. Caitlin Dubois asks, what's the thoughts on Neupogen? Is it worth getting it to use? Neupogen is an expensive drug. There's another drug that can be used that sometimes insurance will cover instead of Neupogen, and it's called Nivastim. And what these medications do is that they rev up your white blood cell count. So if you're on one of these medications and we check your CBC, your complete blood cell count, we may find that your white blood cell level is up to 30,000. It may be 3 to 4 times higher than what it would normally be if you weren't on the medicine. And that is both the desired effect and the intended effect, because revving up your immune system is the reason to use that medication. I don't recommend it for people, first timers. That's part of our immune protocol level 3. I personally typically start with level 2. Other doctors feel differently about that. Dr. Kiltz wisely feels like if you're here with us for a reason, that we should really be pulling out all the stops and using all the medications possible to help you get pregnant. So I think it's worth a discussion, but certainly if you've had a transfer before and it's been unsuccessful, then Neupogen is not an unreasonable choice as we start to increase the immune protocol there. Hey, it's about 30 minutes after the hour, 33 minutes after the hour. If you're just joining on this fabulous Tuesday afternoon, I'm Dr. Randy Fink from CMY Fertility in Colorado, and this is Fertility with Fink and Friends every Tuesday live via internet across the world as we answer your questions about fertility and women's health. People say, well, Fink and Friends, where are the friends? Sometimes I do have a guest here, but you are my friends. So just happy to be here with you. And sure, I'm glad you're all here. Misa K5 says, if I do suppression for endometriosis, do you recommend surgery as well? My answer to that is no. I don't. So there is a non-invasive way to be able to diagnose endometriosis, and that is through a test that's called Receptiva. And Receptiva tests for the presence of a protein in the lining of the uterus that's called BCL6. When BCL6, which is associated with endometriosis, is being expressed in the uterine lining, we know that the odds of a successful embryo transfer decrease to less than 12%. That's really not a good number. So when we find BCL6 and we treat it with suppression, and that's medication that we use for 60 days, and there's a couple of different medications. There's a Lupron shot. There is a medicine called Orilissa. There's a medicine called Myfembree. Sometimes we even use letrozole to suppress the estrogen. When we suppress the endometriosis, we can increase the odds of a successful transfer, increase it by about 60%. So that's pretty significant. The odds are pretty similar if the endometriosis is treated surgically. Now, where do I draw the line? There are some gynecologists who will say, absolutely don't do Receptiva. You should be having a laparoscopy. Laparoscopy, always laparoscopy. Well, what is a laparoscopy? Laparoscopy is a surgery where we, under general anesthesia, place a little camera through the belly button and look around on the inside of the pelvis. Why are we doing that? We are looking for endometriosis. And if we find endometriosis, the recommendation used to be that we would burn it or treat it superficially. Now the recommendation is that we excise it, that we take a little piece of tissue around it and remove it. And why is that? Because the endometriosis that we can see is really just the tip of the iceberg. So we want to be able to make sure that we get as much of it out as we can. Why do we care about endometriosis? Because endometriosis is that normal lining of the uterus that sloughs off when you have a period. But instead of coming out, it works its way north. It works its way into the abdomen and implants within the walls of the pelvis and in the abdomen itself. Why does that matter? Well, it affects the way really the brain is talking to the genitals, specifically to the uterus and to the ovaries. It's like interrupting the flow of electricity. And since it interferes, it decreases egg quality. It decreases fertility overall, but certainly in terms of doing an embryo transfer, it decreases the receptivity of the uterus itself. Is that a problem? Yeah, oh, hell yeah, that's a problem. So in that situation, we can either treat it surgically or we can treat it medically. Well, some people with endometriosis have a pain syndrome. It's the most common cause of severe, the word is dysmenorrhea, which means painful periods. So if you have significant pain with your periods, that every month you are doubled over, you're in the fetal position, you have to stay home from work or school, and that's a kind of a classic symptom of endometriosis. Other symptoms: pain with deep insertion on sexual intercourse, pain with a bowel movement. These are the classic symptoms of endometriosis. And in my opinion, if you're trying to get pregnant and you have symptoms like this, then a laparoscopy really probably makes sense. And why is that? Because we can do something about the endometriosis that's going to help you with your pain. If you have what we call silent endometriosis, which is to say, no symptoms at all, but we found that your BCL6 is positive from the Receptiva test because you've been trying to do transfers and they're not working. Well, in that situation, I think medical treatment is probably a better idea. Is low-dose naltrexone, this comes from SF Nikki, is low-dose naltrexone used during priming for egg retrieval? Yes, it is. Does it help egg quantity or quality? I have a diminished ovarian reserve and Hashimoto's. So for a couple of reasons there, Nikki, I would say yes, LDN, low-dose naltrexone increases our endorphins. And that ultimately has an effect on egg quality. But it's really kind of used as an anti-inflammatory. So when you have Hashimoto's, we know that you have an autoimmune response. Hashimoto's is autoimmune thyroiditis, right? So it's our own immune system is attacking our thyroid gland. And so when that happens, we know that there is an autoimmune or an inflammatory condition in your body. So anything that we can do to try to improve that is likely to improve your odds with fertility treatment. So the answer there is yes. Okay, M. Salustio 2021. Forgive me for my mispronunciation, but nice to see you. 41 years old, third retrieval, taking vitamin D3, ovarian bloom, CoQ10, ubiquinol, resveratrol, prenatal, and fish oil. Had an egg retrieval today, and despite having 8 good-sized follicles, only got 3 eggs. What causes so many follicles to be empty? My hunch is that is it, that sort of defines what we would call an egg quality issue. Sounds like you're doing the right thing on the eggs there. I would certainly add, and so basically what she's saying is that she had monitoring done, showed a whole bunch of follicles, but when they went in to get them, there were no eggs. That some of those follicles, and sometimes these follicles have 2 eggs in them, and sometimes they have none. So what I always tell folks is let's not pay too much attention to what the monitoring said, because I personally have a strict no egg left behind policy. If there's a follicle there, I'm going to place a needle in it and try to get an egg out of it, because you just never know, no matter how big it is. But sometimes there are no eggs. And that means that you've created a follicle, which is secreting hormone, but there's just not an egg inside. Sometimes those eggs will degenerate before we retrieve them, or sometimes you simply didn't manufacture them in that follicle. So omnitrope is one thought there. There's a few other things you're on, many of the right things there, my friend, in terms of those supplements. I would think about adding some N-acetylcysteine. I would think about, you know what, I'm happy to send you the list. But looks like you're doing the right stuff. But egg quality, and maybe please consider some omnitrope. Hi, Brittany, and hi, Franny, and hi, Lisette, and hi, Hanley, and gosh, all these nice people. What causes a failed FET after great graded eggs? And this comes from KC India. You know, the embryo grading thing is a hard pill to swallow, because we like to think of people, we like to think of, we've all been to high school, right? And in high school, your grade in the class tells you where you are relative to all the other people. Are you better? Are you worse? If you got a C, maybe you're about average. If you got an A, you're probably better than most. And if you got a D, well, you didn't do your homework. So what does that mean? Well, embryo grading is not the same thing, because it's not the ability to look at an embryo and to determine which embryo is better. All it's doing is looking at an embryo to say, how beautiful is it? Where does it fall in the beauty contest? And that's a tough thing, because that's not what we're used to thinking of when we're thinking of grading. Originally, embryo grading was developed to try to determine, could we look at an embryo under the microscope? Could an embryologist look at it and determine from looking which embryo was actually normal? The answer is you can't, because any of you who have been through PGT testing know that you can have a beautifully graded embryo that has multiple complex chromosomal abnormalities, whereas your poorest graded embryo may be the one that's completely normal. So embryo grading doesn't so much count, Casey. It really just means that you had pretty embryos, but it doesn't necessarily correlate with the outcomes of whether those are going to be chromosomally normal and be able to stick. So let's see what we've got here. All About D says, I was diagnosed with diminished ovarian reserve and plan to start a cycle in September. Is it too early to begin taking CoQ10? No, it's not too early. The earlier, the better. So ideally, again, 90 days is the best way to do this if you can. If you're using CoQ10, it's the ubiquinol form of CoQ10, and that's usually 400 milligrams a day of ubiquinol, which is a better absorbed form of CoQ10. If it's not the ubiquinol form, then I believe it's 600. What does CoQ10 do? It's a source of energy for our cells, and so it can improve egg quality. So please, All About D, start on your CoQ10 now for sure. Hi, Emily. Emily Mortensen is on the Facebook side. Nice to see you today as we approach about 15 minutes before the hour. So maybe about another 15 minutes, we'll be able to answer some questions here. My husband is going to be doing a TESE with Dr. McBride. That's our male urologist, our male fertility urologist here in Colorado Springs. And he was great on the phone. And I will tell you, yeah, he's a wonderful guy. He absolutely knows what he's doing. And if you are in his hands, you will feel that there is truly nothing to worry about. If I produce eggs and ovulate on my own, will I be able to do a fresh transfer with no medication? Well, so I think what we're saying there is we're kind of talking about doing not so much. So when we talk about a transfer, we're talking about an embryo that's been created with the sperm and the egg. And so maybe one of the things, one of the options there is that so when we have a Tessie sample, and so that means sperm that are taken directly from the testicle, and usually they get 4 vials or so. The sperm counts in those aren't typically very robust, and that may be one of the reasons that he has to have the Tessie procedure, because that sperm is not coming out. We need to go looking in the testicle for the sperm itself. So in that situation, we usually recommend IVF because doing something like an IUI or an insemination just may not have enough sperm. And given that the number of sperm, or given what it required to get that sperm, and that was sticking needles, taking biopsies of the testicle, probably not something that your husband is going to want to have to do again. We would generally recommend that you do a procedure that's going to give you the highest probability of success, and that's IVF over IUI. Now, if you're asking, can you do a natural cycle of IVF, which is where you release your own egg? We don't stimulate the ovary. We just get whatever, we retrieve whatever egg your ovary is naturally making, and then try to fertilize it. Yes, we can also do that. In that scenario, or what's called natural IVF, just like in a normal natural cycle, you're usually making one follicle and one egg. So the question that you have to ask in that scenario, is it worth going through the expense of the process of IVF in order to get one single egg when you've had to go through great trouble to get that sperm? Normally, we would like to maximize your opportunity for success, while doing natural IVF minimizes the opportunity for success. But ultimately, it is your choice, Emily. And if that's something you would like to do, we will support you in that. Brittany Taylor. Hi, Brittany. I have one ovary and my AMH is 4.9. I'm 34 years old. I'm guessing that's still good. Yep, that's a good number. That tells me that your eggs, or that your ovaries will typically respond very well. My last retrieval, I got 5 eggs and all 5 made it to blast. Well, that is fantastic. I'm surprised with an AMH of 4.9 that there were only 5 eggs to retrieve. But hey, to get 5 blastocysts, that has the potential to make you 5 babies. And you're working on a baseball team at that point. So a good deal. Let's see. It looks like Sarah is here on the Facebook side. I'm 45 and I'm going through menopause. The last time I saw my period was in December. I really want to have a baby. Is it possible for me? Well, in that scenario, I would say certainly the easiest route, Sarah, is using donor egg. Now, not to say that using donor egg is an easy choice, because it's not. And if you've heard me talk about this before, I would tell you again, most people don't go into the process hoping to be able to use a donor's egg. But using a donor egg will likely have a pretty high chance of getting you pregnant very quickly. So you would take a donor egg and you select your donor based on whatever your criteria is. We have a donor team here at CNY who walks you through that process. They place your partner's sperm, or donor sperm if you're using it, into that egg, and that creates an embryo. That embryo then goes into your body and hopefully will stick. Every drop of blood that goes through that baby is yours. There is no question that is your baby. And we've talked before about something called epigenetics. And epigenetics tells us that, yes, there are some things that are genetically programmed. So the eye color is going to come from the genes. The hair color is going to come from the genes. But different things about that baby. Is that baby going to be shy? Is that baby going to be an extrovert? Is that baby going to have a great sense of humor? Is that baby going to be mechanical or artistic? Is that baby going to use crayons or markers? All these things are determined by a series of switches that are turned on or off in whatever individual order is mandated by the environment in which they grow, meaning to say your uterus. So now there's even scientific proof that in addition to every drop of blood flowing through that baby is yours. So donor egg is not something to be afraid of. And I will tell you, we'd have a very high chance of getting you pregnant. We can get someone who is 65 years old pregnant with a donor with an embryo that comes from a donor egg. It's merely just a question of getting the body ready. So Ruzik Blue over here on the Instagram side says, if endometriosis is suspected, is it recommended to do a laparoscopy and excision or Orilissa suppression or both? And in terms of fertility, I would say really either there. Like we talked about before, if there is a pain syndrome involved, I certainly think you get more bang for the buck using laparoscopy if you're able to remove all the visible endometriosis. Sometimes you will supplement that also with some medication like Orilissa or Myfembree. But if it's asymptomatic endometriosis and that it's found as a result of the workup for unsuccessful transfers, then I would support using a medication as opposed to surgery. Oh, my friend Alexis in Miami is watching. Hello, my friend. She is one of the most extraordinary nurse practitioners and works at the Miami Center of Excellence. And we have a CNY monitoring center there at CNY Fertility at the Miami Center of Excellence. So if you are in South Florida, it's a wonderful place to monitor because it is a part directly into the CNY system and makes life very easy for tracking down your results. Let's see here. This comes from it looks like Lindsay Smoot. I think I said it right. High AMH, okay, and polycystic ovarian syndrome. So folks with polycystic ovarian syndrome often have a high anti-Mullerian hormone. You did 6 rounds of Clomid and Letrozole, all led to late ovulation on cycle day 25. Okay, and that happens sometimes just because polycystic ovaries can sometimes either be very sensitive or very resistant. So sometimes it takes a lot to try to get them to respond. And that's what it sounds like, Lindsay, there. The first round of IVF, and again, stemmed for 23 days and retrieval on day 25. Only ended up with 1 embryo. So that is a challenging situation. Pardon me. And it really is defined. It defines that type of polycystic ovaries that are resistant. And so what do you do in that situation? You increase the dose. Now, it's hard to sit down and think about that because usually if we had a consult, say for instance, excuse me, I'm going to just take a quick drink here. Thanks. If we had a consult and you told me I have polycystic ovaries and my AMH is a 4.9, I would say, all right, so that we don't hyper stimulate you, your body is really going to be able to go into egg making mode here. So that we don't hyper stimulate you, I am going to give you a lower dose than expected. Because I'm anticipating that your ovaries are really going to pay close attention and are going to give us a lot of eggs and consequently a high estrogen level and the potential for ovarian hyperstimulation syndrome. Well, Lindsay, your ovaries, they're kind of going like this. Da, 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 don't talk to me. I don't hear you. So in your situation, we'd actually want to give you a higher dose than you might expect in order to get those ovaries to respond. Very unusual that you would respond, that it would take 23 days to get you ready to trigger. So next round, higher dose. And that's the way that you do that. We've got about 4 more minutes here. So let's see if we have another question I can throw in here real quick. I'm rocking that haircut. Thank you. Remember, business in the front, party in the back. How long do I suggest taking progesterone to initiate a period? So usually what we do is we use Provera for that. If we're doing it orally, Provera is also called medroxyprogesterone acetate. The original sort of formulation for that was 1 pill a day for 10 days, and that would give you a period. Most of the time when I'm prescribing that, people are ready to get their period. So instead of 1 per day for 10 days, 2 per day for 5 days, and that will have the same effect. You can also get a PIO shot. 75 milligrams of progesterone in oil will induce a period as well. It's me, Callie, says, I had a transfer 11 days ago. Beta was at 5. So I think we're out this round. Just curious if this level of HCG indicated that my uterus was not receptive. Well, no, I don't think it's a receptivity issue. And in fact, we've seen ongoing pregnancies happen where people are barely positive at that first blood test, especially if they're doing a beta at the midway. So don't throw in the towel just yet. Don't throw it in just yet. We'll keep our fingers crossed there. Let's see. Over here on the Facebook side, we got a bunch more questions here, so I don't know that we're gonna be able to get to all of them here. Maya, I can't read from where I'm sitting here because it's time to get some new glasses, but says I had a trachelectomy. That means cervix removed. Removing the cervix is called a trachelectomy. I had a trachelectomy in September of 2021. Have you had any success with someone who doesn't have a cervix? Started my journey at the Albany office a couple of months ago. Well, so the answer to that is yes. It's a complicated situation. In that scenario, if the uterus is in place, but the cervix or the opening to the uterus has been removed, and that's a fertility sparing treatment that is used for folks who typically have either a cancer or a high-grade precancer in the cervix. Oftentimes they'll do what's called an abdominal cerclage, and that's where a stitch is placed to hold the uterus closed. So getting that person pregnant is certainly possible. It becomes a high-risk pregnancy, but can it be done? Yes, it absolutely can. I would encourage your close consultation with both your obstetrician and with an MFM perinatologist, maternal fetal medicine specialist, who typically are the docs who will do those abdominal cerclages. Myrna Lopez from Miami joined looks like on LinkedIn. Hi, Myrna, nice to see you, and tell your husband hi for me as well. Well, folks, it looks like we are going to have to be wrapping it up today. Remember, this fertility journey, it is not your book. It is only a chapter in your life, and we are doing everything that we can to try to help you rewrite this chapter. Every Tuesday at 4 o'clock on the Mountain Time, it's Fertility with Fink and Friends live from Colorado Springs. I'm Dr. Randy Fink, also from CNY Fertility at the Miami Center of Excellence. Thanks so much for being here. God bless to everyone, and I wish you all a wonderful rest of the week. So long.